Well, it has to be. Colleagues, thank you very, very much for joining us today, to choose us in this trip this morning, to choose us in this session. This session is called Strengthening Health Systems Resilience by Exploring Recent Responses to Migration, a resilience testing and policy tool. It's a session organized with the Forum Gastein, with the support of the Observatory. So what do we mean by this? And I'm glad. To some extent, it's not bad that we have few people, because that's going to allow us to have a lot of debate on what we want to do today. So we are trying to look at resilience and migration. We're trying to use migration as a lens to look at resilience, as well as trying to identify the kinds of strategies to strengthen the health system, prepare the health system for the shock or the challenges of migration. So resilience, as we'll hear in a minute from Ewout van Ginneken, is the ability to prepare for, manage, absorb, adapt, and transform and learn from shocks. So the challenges to the health system, be it foreseen or unforeseen. This is a concept that has been very much linked to COVID, but I like to say with some pride that we, in 2017, published a brief looking already at the concept of resilience, a very useful concept to understand, as we said, the preparedness and the way that the health system reacts and responds to shocks. So that's the first dimension. The second scope is migration. So undoubtedly, migration has, and we've been talking about a lot about Ukraine today, has tested the resilience of our health systems. And it is very much at the core of this year Gastein. If we take the 3Ds, migration falls to some extent within the demographics. It changes our demography by our migrants. It's somehow a response to our aging populations. They come here to help us to a large extent, and with lots of challenges in terms of social and health protection. Digital is both an enabler and can be a challenge and a threat to migrants. So digital is an important element. And finally, of course, democracy. With all the populism around migrants and migration and all those responses, and migration related as well with a fundamental human right. Obviously, migration issue today belongs also very much to the democracy D of Gastein. So the objectives today are as follows. As I said already, we're using the migration lens to better understand health system resilience. And for that, we are putting forward a resilience tool, assessment approach, a tool that the Observatory OECD, under the leadership and support of the European Commission, of DG SANTE, we put together this tool. So we'll show you this tool. We'll apply it to migration together today. How do we assess the health system responsiveness and preparedness and learning from the shock of migration? And of course, the tool is not just a tool. It's not just a way to practice and do an academic exercise, but we want to finish the session today by identifying some best practices as how to address migration in our countries. So I will start with, just to give you a sense of what we're going to do, we're going to start with a presentation by Ewout van Ginneken, who will be giving you this framework for resilience and start threshing out these issues around migration. Then we'll hear from the panelists. I'll introduce the panelists in a moment after Ewout speaks. So we'll hear their own perspectives from national and international level. And very soon then we'll ask you these questions. We'll put them on a slide about the responses of the system. And I'll ask you, so if you sit by yourself, you'll have to discuss with yourself. So if you could get closer in a minute to small groups, and then you work together, we'll do buzzing groups to try to understand your reaction, your responses, your views on this area. And again, I'm happy actually the small group because we'll have lots of fun debate about that. So Ewout van Ginneken is head of our Berlin hub, and as many of you know, is the director in waiting of the Observatory. He'll be taking my job. Ewout, you're taking my job, you realize that? From the 1st of January 2025, and it is indeed an enormous pleasure to have Ewout introducing this issue. Ewout.
Well, thank you, Giuseppe. Now probably everybody hates me after this introduction, that I will be taking your job, Giuseppe. But anyway, a very important subject that we will be talking about today. I'm very pleased to be part of this panel. It's really also a topic that is close to what I've been working on. We all know, and we've seen in this week, that health system failure really undermines solidarity and social justice in health systems. And that health systems really have an important role to play in showing that the social contract works. And therefore, it's important that we understand how we can strengthen our health systems, that we are even better during times of crisis. So therefore, really, we have this policy tool that Giuseppe already talked about, the resilience testing tool. It is a really important document. Please get your phones out, not to make my picture, but to use the QR code to download it so you can read this important document. And we're going to see how we can apply that to the case of migration, because migration is a real-life, continuous, ongoing shock that is testing our health systems. So the pandemic was a real shock and also the topic of previous forums. But migration perhaps should not, because we have migration all the time. But still, the war in Ukraine has displaced many millions of people, and many of them are living currently also in the EU. And one very powerful tool, resilience tool I would almost say, is the European Commission's Temporary Protection Directive, which was set up actually after the conflicts in former Yugoslavia. And it served us really well. It really provided coverage to many, many people all over Europe, although it only actually asks for emergency care and all necessary care. Most countries have interpreted this as providing the same level of benefits as the citizens of the respective countries. However, we've done 2 reports. Isabel, who's also on the panel, asked us, the Observatory, to do a report on access and also on the coverage of these and the implementation of the directive. And we found that there were still problems, obviously, in accessing these services. So it still exposed weaknesses in the systems that we will be exploring today. So a truly resilient health system would respond well to a shock, and the shocks are very different in nature, so it helps to think through economic, environmental, or disease. But still, many aspects of shock, if you cannot reach a hospital because there's a flooding or a transport strike, it ultimately is the same challenge. So therefore, how are we going to test our resilience in the systems, and how can we improve? We are using the WHO Global Framework for Health System Performance Assessment as a lens. It shows all the interconnectedness in the health system, the functions, the intermediate objectives, and the final goals. And we use those to map them together with the shock cycle and see how a system reacts in the various stages of the shock cycle, giving us important insights of how the system reacts. So in this panel, we will be focusing on migration, obviously, and there are some commonalities in the response that we see in terms of migration. So access and social protection are, of course, really important, and we've seen that the importance of the Temporary Protection Directive, but also funding models, also to maybe give a little bit more financial protection to these very vulnerable groups. Workforce and capacity is, of course, a big issue because of the cultural sensitivities, the language barriers, but also perhaps they can play a role as part of the response, because there are many qualified people also migrating here, and who could also fulfill a role in the system, maybe part of the solutions, so that we can think of long-term solutions, what we will discuss here in the panel today. So I hope that you agree with me that resilience testing is an important element, and that is something that we should use to scan the horizon and see whether we can improve our systems, and discuss it with our panel here. Evaluate the strengths and weaknesses, focusing on resilience over time. develop actions to address it better, etc. That will be the content of this discussion today. Becoming more resilient for the future. I would like to end, before I give it back to you, Giuseppe, thanking, of course, DG SANTE and Maya Matthews and her team for giving us and our OECD friends this opportunity to do this important work. I would also, of course, like to thank our OECD Health Division friends, Phil, Nomi, Ines, and Federico for, the great collaboration. I would like to thank the pilot countries, Finland, Greece, and Asturias, for piloting this work. And I would like to thank our own Observatory team, John, Charlotte, Julia, and Marina, for leading on this important work. And I would like to thank Susie, who wanted really to be here, Susie Lesov, our Deputy Director, who I'm replacing today, and is very sorry that she couldn't be here today, and I look forward to the discussion, Giuseppe. Over to you.
Thank you. Can you put the next slide a second? Yeah. Okay, perfect. Thanks very much. Right. Thanks a lot, Ewout. You really help us to frame the issue today. An issue that we then threshed out with these 4 questions that will go back to you in a minute. So if you start seeing at these questions, because we like you to help us, to help each other in answering them. And I'll start with the panelists to do that. Lots of self-marketing, Ewout, but indeed, this is a really useful volume to look and assess health systems. So we wanted to put that in the table, and very much thank you to the Commission that has led us in doing that work. So let me now introduce the protagonists today. We have in the panel, I'll start with the right-hand side, Yanis Natsis, Director of the European Social Insurance Platform. We have as well Elena Bal, a Migration Health Officer at IOM. We have Lilian Bildiridi, also Greek, actually. I happen to be 2 Greeks, but you are not representing, you are representing Greece to some extent, Secretary of State. But Yanis, as we said, is head of this ESIP organization. We have Jarno Habic, the WHO representative in Ukraine, and Isabel de la Mata, I should have said first, Principal Advisor at DG SANTE. And we have here as well Carolina Shumilo from Ukraine, actually. So it's very nice to see Gastein joining us in trying to summarize from you, although being fewer people, I prefer to hear your voices. But from you, and particularly those online, welcome to all of you, those who are online. Please send the responses in particular to these questions that we have on the screen. Well, we don't have them on the screen, we'll have them in a minute. Let me start with you, Elena. I mean, I'm going to show my own ignorance to the beginning, okay? What is a migrant? Because, people say illegal migrants. We don't like that, of course. We call documented. We talk about asylum seekers. We talk about they move because of economic reasons, disasters. Can we share a terminology today that we understand each other what we're talking about? Use the microphone.
Hello? Yes, absolutely. Thank you very much. So indeed, accordingly to the IOM definition, a migrant is a person that is away from his or her place of residence and origin. So we are a bit all migrants. But then when we talk, there are different types of migrants, and sometimes across the general public, indeed, there is some confusion, especially when we refer to Ukraine and so on. We can have refugees that are individuals that are fleeing areas where indeed there may be conflicts or flooding or climate change related matters and so on. So people that are fleeing an emergency. There are then migrants that can be economic, and often they happen to be also undocumented migrants, so migrants that are not legally registered in the country of hosting, or that are enduring a journey towards open country of destination. And then there are documented migrants, so myself as well, you, whoever it's indeed moving across and outside their territorial boundaries. An interesting group, it's for instance, and there we have some differences with the EU, IOM sees Roma as migrants, while often they are EU citizens that are indeed mobile within the EU, but indeed because of the definition of IOM, we see them as migrants and indeed they are vulnerable. So in a nutshell, maybe I touch upon, and indeed then you have the Ukrainian population that it's particularly specific because there are displaced migrants within Ukraine, so people that left their city of origin to go to other cities within Ukraine, and also broader, some people call it still displacement, when it's outside Ukraine, for instance. So, and I then recommend everybody to refer to the full definitions for more information at legal level.
It's very important for discrimination reasons, needless to say, as I hinted at the beginning. Also, the whole response of the system, the coverage, the finance changes entirely depending on the type of migrant we're talking about, and we'll take that into account in our debate. So, my questions for you today, to the group, and to a large extent to what I'm going to ask the panelists is, what kinds of health systems weaknesses or strengths migration is posed in your country? And what we like to talk about today very much from the resilience framework perspective, are these challenges new because of migration, or they were there and they were bound to come out as well with other shocks and challenges? Something, Elena, I should have asked you earlier, but I'll say it myself. Elena keeps telling me, Joseph, migration is not a shock. Migration is a continuing process, a continuous challenge, or not even a challenge, a phenomenon that we should not call a shock, and I agree with you, Elena. What key national strategies have been put in place? That we want to learn about that. What kinds of markers, if a country wants to see whether they are prepared for migration or they are resilient, what kinds of markers would be particularly relevant for migration resilience? And of course, what about the EU level? I'm not going to ask all these questions to you in 10 minutes, but you're going to choose in your groups one of these questions. So let's start with the panelists. I'll start with the country. I'll start with Liliane. You know, it's frustrating, Liliane. I mean, we had dinner together. I learned so many things from you. And I think I'm giving you 4 or 5 minutes, more or less, to explain all of them. So we cannot explain all of them. But there are many things you could share. One of the things that surprised me in your health system preparedness and your reforms was that actually migrants, regardless of origin, regardless of documentation status, have universal full access to all the benefit packages and services in Greece as any national Greek, whatever national Greek means. Can you expand that a bit more for us?
So I'll begin by saying that migration influx has increased in 2024 in Greece in comparison to each month in 2023, but not to an extent that it is strain to the health system or that it made the system unable to offer quality services to all. We have pinpointed the points of entry which are known, such as Evros, North Attica, Chios, Lesbos Islands, and Kos, which are on the western Turkey coast, which gave us the possibility to somehow prepare. And when I say prepare, what I mean? We made some adjustments. For example, we recruited doctors in auxiliary positions or with financial incentives of 2,100 euros on top of their salary, as well as ensured accommodation to make sure that for a short period of time of 1 month, 2 or 3, they would be on those islands. We made pre-secured number of beds to ensure bed capacity should an influx occur, and of course coordination with the Ministry of Migration and shelter facilities. And as you mentioned, of course, the access to health care is universal at all levels. So to give you an idea on why we say it didn't pose a strain so far. So in the past years, there has been an increase in the budget the government gives to healthcare, although Greece has historically been very low on that front. So to give you a comparison, from 2023, the allocated budget for healthcare from the government was 11.9 billion. 2024, it was 12.8 billion. And for hospitals alone, it experienced an increase of 500 million. Now, if we take the budget of 2023, we would see that only 300 million were uninsured patients. Of these 300 million, as a total.
We include
yes.
perhaps Greek citizens or others
Exactly.
that could be uninsured,
Of
as
which,
well all this group.
Exactly, the
And only,
largest
please
number.
echo that, I want to echo that. We talk so much about protection and expenses of migrants uninsured, 300 million.
Not even. 300 million was uninsured altogether, of which 175 were Greeks which were uninsured. 37 of those million were non-nationals uninsured, and almost 2 million were migrants.
I think this is important numbers that we remind ourselves. Quickly, Lilian, let me take advantage of all the many reforms you're putting in place. To strengthen the resilience of the health system is the reform of your health workforce. And what you taught me, so let me echo you, is, Joseph, it's not about migrants. It's about us strengthening the resilience of the health system, which happens to be good for migrants. Could you tell us a bit more
Of course,
about these reforms?
Should have migration been more pronounced, Greece would have serious challenges to face. I would begin by saying about the uneven distribution of the health workforce within the system, if you take into account needs. If you take into account, for example, remote areas and islands. So this is why, in the past 2.5 years, we have been trying to allocate the workforce in permanent positions based on the openings we do, with econometric modeling, which takes into account actually what do these hospitals produce? How many people, as in each area, do they respond to and they have to cater for? And take into account, of course, proximity to other hospitals, the ambulatory care in the area. So given that we are doing oral planning for the health workforce, on top of that, we introduced financial incentives, which is for movement to cater for an immediate need, for example, an influx of migrants, which is around 2,100 euros per month on top of salary with accommodation. And of course, to address permanent problems, because we have specific islands which over the years wouldn't have interest from doctors to go there, we introduced monthly increases. I mean, so far, if you go to a remote area, a doctor would get approximately 800 to 1,000 euros at the end of each year. Now we changed that to 2,000 to 300 euros, depending on the remote area, which increased considerably. And something else which I want to mention, usually we say we have a lack of doctors. I wouldn't put it that way. For example, in Greece, we have a lot, more doctors than the EU average compared to our population. We have a problem with nurses. However, we have a problem with specific specialties like most countries. Anesthesiologists, pathologists. So what we did is this financial incentive, which is monthly now for these remote areas, doubles for specific specialties. And of course, a last point, with the WHO country office in Athens, we are doing a big project in order to have a human resource information system, which will have aggregated data for the whole workforce platform in the country, which will also create prediction models for future needs. And hopefully we will have that ready mid-2025, so hopefully that would be a point.
We need to invite you back in Gastein to hear about the impact of all these incentives. And indeed, what I like, Lilian, about what you did is you went beyond migration and you said, listen, I have a problem with human resources, I have lots of doctors, but I have a problem of distribution, and should I have more migrants, I would have a problem because the distribution is okay, and all this range of incentives which look forward to the results. Yanis, You are, as we said, in ESIP, technical an NGO, actually, are registered as an NGO. We're talking about, because we should have had an NGO in the panel, by the way, so we hope NGOs in the room will contribute in particular. But you are an organization of social health insurance, insurance organizations, finance. We discussed many issues. We talked a lot about social protection. You said it's not just health, Joseph, it's about social protection. We talked about who pays the bill. I'll let you reflect on those.
And I was inspired by a lot of things that Lilian said, because, well, ESIP members, social security institutions, statutory social security institutions, they have a very close understanding of what's happening on the ground. And we see this with all sorts of crises. And as Lilian didn't only focus on migrants, it's indeed about extending coverage and the access to social protection overall within a migrant situation, a migrant crisis, although it's a phenomenon, it's not a crisis, we said, or not. And therefore, perhaps in relation to the Ukrainian refugees, migrants and refugees, perhaps we can start by saying that, for instance, our Polish member, ZUS, because we have members, a lot of members and it's the biggest social security institution, and we have other members in other Central and Eastern European EU member states, immediately mobilized in order to grant a social security number to a huge number, 1.5 million people coming in from Ukraine, and especially, as you remember, in the early stages, because of course the situation, unfortunately, since the war is dragging on, has evolved over the years, to grant them access, especially to women with young children arriving, for instance, in Poland, but also in other countries, so they have access to the healthcare system, but also to educational facilities. Then the question of employment services, and that was extremely important for the integration and the equity. Of course, the situation has evolved over the past 2.5 years and counting, and therefore there are questions, and that varies considerably from country to country, as to which benefits they have access to, how the host country assesses the situation and evolves the situation. What if we see also numbers of Ukrainians, and you had it also on your map, there are also people returning to Ukraine, and many, at least that's what we hear also from a lot of our members, their desire is not to stay permanently in the country, but go back to their homeland. Therefore, what happens in those situations? Do they retain the access to the benefits? And that brings me to the point also made by Lilian, in the sense that it's not only about migrants coming in from Ukraine, for instance, in this case, it's about the transferability of benefits, the status, the mutual recognition, the applicable legislation. So issues which, for us, as social security institutions, they're permanently on the table.
But can I ask you,
yes.
I'll ask Isabel, we want to hear in a minute from the Temporary Protection Directive, a real key success. I don't want you to answer as a SIP, Yanis, because the SIP perhaps has a position on that. But the $1 million question is good for Ukrainians, and what about the rest?
No, I would say
not as a SIP.
It's a win-win, I would say. No, it's not.
Can we do that? Can we do that for others? Can we apply? I cannot ask this question to you, Isabel, I won't. But shouldn't we be able, I'm talking as nobody, be able to apply that to other, I'm sure Elena will agree with me, to other migrants?
The approach, starting also from the Greek example, but also from other member states, honestly speaking, I don't hear a discriminatory approach. Of course, we see nowadays, and social security is a highly sensitive and political topic, right? I mean, we understand it. So the question of granting access to benefits and the question of contributions is highly sensitive. But at least I can tell you honestly, without going into the details, because again, the situation varies from country to country, and of course from time to time. I mean, it's not the same situation as it was in 2022. The approach is to be homogeneous. It's not to discriminate. And that even creates a few problems, perhaps. One could say that if you equate, for instance, in this case, the Ukrainian migrants with the rest of the national population, then you expect from them that they also have to pay contributions. But of course, they're not in the same state, or they don't start from the same starting point. So that just to say that confirms perhaps that it's a non-discriminatory approach, although this is a very generic and simplistic, perhaps, response to your question, because
No,
again,
it's an excellent one. It's an excellent one that's our direction, and there's his rights and duties as well involved in this social contract. Very briefly, because we need to move on. you're saying social protection as well. It's not just health,
Yes.
but social protection. And you're saying already about the insurance number and so on. But we have an issue there as well.
Yes, and
In
you
the
know,
resilience.
even on the EU bubble, we had, thanks to the Belgian presidency, we had actually exactly 1 year ago, you remember, we had the Belgian minister talking about the work of the Belgian presidency on access to social protection. And there, for us, it is a key topic, which has a lot of dimensions, from the gender dimension to access to information. And of course, in light of the migrant situation, you asked, is it really a win-win? I would say it is a win-win, and it does highlight, as in your question, existing problems. So that remains a key dimension, and it remains to be seen also with the new Commission, how high is this going to be on the agenda?
Perfect.
And how member states are going to monitor their progress when it comes to access to social protection.
That's absolutely perfect. Ewout, you must be happy because we are already covering several of your dimensions of coverage, access, finance, human resources, all key dimensions on this resilience framework we're trying to sell you today badly. Isabel, I'd like to congratulate you, the Commission, representing the Commission today, by a temporary protection directive. It's been a key success. Can you tell us a bit more about the success of it, as well as some of the challenges and questions that you see from the Commission?
The first thing to say is that the Temporary Protection Directive is not the Commission, it's the Council, the ones that decided to give that. No, it's important because they were the member states. So there was a directive, and that the Council is the one that decided to activate in March 2022, and that and it's been extended now is until February 2026. So it's a dynamic process. Second thing is that the Temporary Protection Directive, what it was trying is to give access to a series of services, not just health. Health was a minor part in the whole text, to the persons that were displaced in the European Union from Ukraine, not Ukrainians, from Ukraine. This is important. And the aim was...
Can you say that again? Not Ukrainians, but from Ukraine. Any nationality that was based in Ukraine that is displaced is under the directive.
The persons that were in a long term in Ukraine legally, let's say like that, they didn't have to be Ukrainians. They have to live in Ukraine when they came here. And what the temporary protection offer was the right to establish in the European Union for a period that now is going to be 4 years, and to move around the European Union. And this is also important when we are talking or comparing with asylum seekers or refugees, in the sense, our refugees, not your refugees.
Careful with the microphone.
So the legal definitions are different because they are not assigned a place where they have to stay. They can move wherever they want and change the country and keep the benefits. I mean, they need to request a new right of residence in the new country, but it's not a problem. And this has been one of the challenges, to convince the persons that if they are moving the country, they are not losing the benefits. If they are going back to Ukraine and they come back again to the European Union, they don't lose the benefits. So that because at the beginning there were people that were accumulating, so requesting this residence, temporary resident permit in 4 countries. They were moving countries and they didn't say that they have led. So it was.
So Isabel, are you saying that when this displaced population go back to Ukraine, which we hope will happen soon by winning the war, hopefully, these people will be able to go back, the Ukrainians, to the European Union countries and be protected?
Until 2026, we have this solved.
Until 2026?
Yeah, we hope that there will be no need after 2026, and if the things are solved at that moment, they will be like any other...
There's still cross-border transfer between member states,
as any other candidate country or as any other EU member state. So let's see where we are.
Has it worked? And then I'll ask Ewout in a second for some of the data as well. Has this worked? Are you happy with the extent that your member states have responded and implemented the directive?
We are very happy that first that they were the member state that decided to do that they did that we have checked, and EWOOD has checked, and all of them have implemented the legislation, even the ones, there is one, that was not obliged to do that, exemption on that, and this country did it, so, and the EA countries and Switzerland, so everybody has offered this opportunity. And we know that it has been very difficult, and now talking about health, very difficult to some member states, the ones that receive more persons. The problem is not that, that they come from Ukraine. The problem is that there are a lot of people at the same time that arrive to a country, to a health system that could be already struggling or not, depending if it's a huge member state or it's a small member state, and with people that comes with specific needs, especially at the beginning, psychological issues, the language, of course, the fact that most of them were women and children and elderly population. So how to adapt to that system? That was the real issue and the real request from the member states to adapt, to provide the healthcare to this population.
Perfect. Thank you.
And we are trying to support them with different finance mechanisms and etc. But in principle, we are proud of the member states and how quick they responded and how well they responded.
Brilliant. 30 seconds if out, because we're running out of time. I want to go to the audience. Well, I'm sure in the audience, the participants here, the question in all of you, but I'm not going to ask you a question, you may want to ask this question later, is that would be an ideal mechanism to cover all migrants of all kinds of documented and undocumented migrants. But I'll leave it here hanging in the air. Ewout, 30 seconds, is it true? I mean, you did research under the leadership in terms of reference of Isabel de la Mata, the Observatory did that. You did that twice, longitudinally. Is it true?
So there's always a discrepancy between theory and practice, and that is a relevant issue to any migrant and undocumented migrant that we see. So you mentioned data, Giuseppe, and data is the big issue here. I think that this again revealed that we are not good at collecting data on vulnerable groups. That I think that most data overstates the numbers of people who have coverage, that we have a larger problem than we think with people who have no coverage, and that could be homeless people, that could be migrants from anywhere. So we need to improve our surveys so that we have better data. And also, I think our challenge in this project was that, yes, we can see what countries have implemented on paper, but then how it in practice works and how the access is arranged. We know there is, from earlier research on migrants, that there's a huge discrepancy. And I think that was the case here too. So there is a need for more research, get better surveys in place, especially surveys that specifically, I think, target vulnerable populations, any vulnerable populations, so that we know more about their unmet need and we can act accordingly. And I think this is something that we've been talking about for years, but we should really take more action on.
Very important on the resilience of the health system, to be able to look at the needs of this vulnerable population, isn't it? So that's exactly. And actually, Jarno Habic, I'm impressed about all the publications that the Office of Ukraine is producing on the needs, on the changes, on the reforms. I was asking Jarno as WHO, what is WHO doing and so on, and we're talking about, and Jarno was saying, Joseph, I got 7 million Ukrainians all over, but actually I have 3.5 million Ukrainians displaced within the country, with an enormous challenge for the resilience of the health system. So can you tell us about the kinds of challenges, and because that's also a form of migration, even if they are the nationals moving around.
Thank you, Joseph. And yes, I think we captured a little bit is a migration shock, and migration is not the shock. I think the shock that we had on 24th of February 2022 was the full-scale invasion, and that has created a number of disruptions and millions of people. And I will focus more on 3.5 million in Ukraine. And I think one lesson learned is the reforms that have been done in Ukraine since 2016 that has helped us to respond and the country to respond much better. Because also we need to go back, the war started 2014. And then the health reforms were not on the same stage that they are now. And then it was much more difficult to act because when we look to the 2020, 2021, we had 800,000 internally displaced also. What we have seen in the last 2.5 years is that the health financing was adapting very quickly in the first months, the way how it was financed. It's universal coverage, but then how the hospitals were paid, by how the primary care was paid, was actually a response to the shock. So there are many aspects to learn. Also, for all the IDPs, the way how you are...
change the payment system of doctors?
Exactly. No, the payment system
the contracting of the primary care and hospitals?
The way how it was...
To accommodate for displaced?
To ensure that actually those who are displaced, they can go to the primary care doctor that they were not enrolled. And what was important was that there was a deregulation in the first few months for the first year. And now, 2.5 years later, the country is again looking to the patient list, looking that you need to enroll to the primary care doctor where you now live. So there was a deregulation to ensure access to respond to the shock, but then again the regulation and to clean the system. And I think that's an important lesson to learn. When I was just looking to the data also, what is the latest, what we see also that when we have internally displaced, in the first months when they are in the new place, they might not know where the primary care doctor is. We see that every third internally displaced during the first 3 months, they don't know where the doctor is. But when we look to the data 12 months after, we see that they are already enrolled to the primary care doctor. They know where the primary care doctor is. And this is also...
And what does that mean, Jarno, that you did lots of communication campaigns? What are the lessons for countries that have displaced populations? What can we learn? We learn about finance, we learn...
It is about the communication campaigns. It is about knowing where that you actually ensure that IDPs know about their rights. It's ensure that they have that access. But also in the frontline oblasts, what we look, still the humanitarian response plays also the role. We see that, for example, 10% of IDPs are having their medicines from the humanitarian partners. So it's how your own system is adapting, and then where there are huge needs, then also how the humanitarian community can step in, but without disrupting your own system as well. So there are a lot of lessons, but as somebody said, the war goes on. So I think the book of lessons and how to respond is still to be written, but what we see is the health system reforms pays off. You need to have proper health financing system, proper institutions in place. You need to have courage to deregulate to ensure that actually your population has access to care, but then you need to regulate
to re-regulate.
And then you need to regulate back, because otherwise you have a chaos down the road. And I think that's a lesson learned, that you need to actually work on all those aspects at the same time.
Perfect. Lots of lessons on governance. In COVID, we learned to deregulate, to re-regulate, like in digital and other areas. Perfect lessons. Elena Val, last but not least, and if I may say, in front of the others and not get upset, the one that knows the most on the issue of migration. One thing that struck me in our conversations, Elena, I learned an awful lot from you, is you're saying actually inclusion is cheaper than exclusion. Tell us more about that, because that's the way we communicate to our policymakers. That's how we make human rights a reality for migrants.
Thank you, Joseph.
Health rights.
Thank you very much. Indeed, there is scientific evidence, and we need it more and more, that the inclusion of all migrants, documented, undocumented, asylum seekers, and so on, within the health systems where we live, it's cheaper than the exclusion. It's maybe obvious to the workforce and experts, but it's not obvious for the general public. So it's something that should be reminded. Member states, especially within the Ukraine response, within the European Union, also thanks to the support received through EU4Health and the work done by IOM and WHO together with them and the European Commission, have been showing that there are a lot of good practices for inclusion from the administrative point of view, but also from the operational point of view at field level. Because indeed, there are laws in many countries that are inclusive. Greece today was explaining, but there are still barriers, often administrative and so on, that can be enabled then to and eliminated to ensure that migrants know where to go, know with whom to speak, can speak in their national languages, and I'm talking about health mediation and navigation. For those that are not familiar, it's about indeed having people from their own language and their own culture, enabling their knowledge and access about the rights that they own, and many member states support, and to be able indeed to get integrated. This integration will avoid and will enable discovering of chronic conditions, for instance, that if not treated at an early stage will become hugely expensive for the health system, and this is one of the many examples.
Short-sighted to say you can go to accident emergency, but you cannot go to primary health care, right?
Absolutely.
Tell us more about you have so many examples of best practices and using our resilience framework in terms of integration, in terms of communication, in terms of support. You're talking about Navigator, for instance.
Yes, indeed. I will refer to the work done in Poland or the work done in Romania by the member states, where indeed these figures are there from the beginning of the war and the influx, and they've been now supported further under EU4Health, where mediators are there. They are often Ukrainian themselves, or they speak the language, and they are really accompanying physically migrants to visits or informing them through leaflets or other means of communication. And this integration doesn't come only from the beneficiary to the health system part. WHO colleagues first, and we, within our capacity, we also support the education and integration of the health workforce. Poland, again, was one of the first countries to make sure that the health workforce fleeing Ukraine and coming to Europe was able to put at work in this
How has that worked? Because we all talk about that. We learn a lot from the Commission as well, and the work Isabel and the Commission is doing in the whole directives around titles and so on, and professionals and so on. How does it work to integrate migrants into the health system? Do we have evidence on that, Elena?
We do have evidence, and it's not a one-shot solution. So I think the work that you are doing also at research level can assess those practices and also promote the sharing of good practices, because Poland proceeded, for instance, through decrees and so on. So there are different methodologies and different histories behind, like Moldova, not yet a EU member state, had already in place some legislation and also a different setup. European countries have a legal frame that it's European and then the national one and so on. So there is not one-shot solution, and it's really important to assess what is good for the country, what is efficient and effective, and also to enable this workforce in the future to be mobile or to return, as we heard yesterday evening, home to their country of origin.
Perfect. One final, very quickly, this is so important in the health system's resilience, in the health systems dimension, is digital. Is digital enabling, or is digitally obstaculizing it? Because we talk about digital as a strengthening of resilience. How is it for migrants?
Thank you also for this question. We are here in Gastein, and it's very important, but at the same time, as you all know, there is United Nations General Assembly that just took place, and there is a document called Plan for the Future that has been signed by many. There you find digitalization and you find migration among the topics. Migrants need to be included in the digital reform of the countries. It needs to be enabled in a cultural and digitally sensitive way, and need to be forecasted for the reasons that we just mentioned. When there is a shock, And indeed, I stress again, migration should not be a shock, but influx and so on. I saw personally, and we saw that it was not easy to deploy immediately ad hoc digital solutions because it takes time. Digitalization, it's a complex animal, but at the same time, if we have in place, again, digital health systems that are migrant-friendly and diversity-friendly, vulnerable people-friendly, because I will not just go to migrants. We are IOM, but we think about also other populations that are vulnerable. Then the access is rapid, and the service, it's easier.
And the beauty of all our panelists is that what they talk about resilience is really applicable to resilience, to other shocks, to other challenges. Now I'm going to ask you something that I dislike when they do that to me when I'm in an audience, which is having to do some work. I dislike it because I like to do my emails, I like to chat a bit with the neighbor, I like to listen what they're saying, the panelists, but please help us to get into small groups. And bus groups, just 10 minutes, please. Look at these questions, take one or two, 1 meter, and just chat a bit and then come back to us. And let's have, we still got plenty of time. Not as much as I wanted, but please try to think through, come with good examples, challenges, ideas, markers, anything, please. And then if you don't want to say it, send it to Caroline, who's paying attention. And then I'll ask you some questions as well, if you want to contribute. Do you mind to do that for me, please, for us? Thank you. Sorry, I dislike it, Fred, like you. But you have to do it. Come on, do it for me. Paul and you can talk. Come on, Paul, leave your emails. Come on, talk to Fred. Can you guys sit together? You're sitting together here, that's nice. Tapani, you find a group? You find a... Yes, if you don't mind, yeah. Sorry to ask you to move a bit, but take any questions you like. Oh, can you put back the questions, please? Whoever's in charge of the slides, can you put back the questions? There's the slider, yes, the slider there, yeah. Sorry to make you work. Any of the questions? I dislike when people ask me questions like that, you know. But please, do help me a bit. Please. Really? Are you clear on those? Shall I start with you then? In the feedback, shall I start with you? In the feedback from the audience? You want to... You think you'll be able to organize it according to that or no? Or shall I mix it? Shall I...
Yeah, probably because I work so many questions the challenges that migrants face.
20 minutes. I'll go over 5. I'll go over 5, please. Just 5, please. People are excited. Come on, it's working. And no, yeah.
250.
Sorry?
There are a lot of questions.
Really?
Yeah,
Friends, I hope that the discussion together has already given you lots of thoughts and ideas that will not be able to report back, and this is not about reporting back. Maybe I should leave you like that until then. It's much more fun. People like to continue talking. Okay, so what we're going to do now is we're going to take those questions. We're going to take those questions. I have no authority left, eh? Dorley, help me, please. I have no authority. You're a co-organizer. People keep talking. Enough democracy and participation. I'm the steward, please follow me. Okay, colleagues. I hear from Caroline that everyone, as always, is into challenges, you know, but I hope there are also good practices and strategies. So I'll start with Caroline. What we hear from Slido, from the online, from people in the room? If there are any questions, I'll ask you to pay attention, and please, in the panelists, not to chat with each other, and respond to some of those. So I'll allocate them or you take them for a final roundup.
Yes, we received a lot of answers to the first question, and mostly people will mention that there are cultural and linguistic barriers like the health system is facing right now in different EU countries. And also there are a lot of a lot of people mention a lack of data and on health status of migrants and their need of healthcare. Yes.
So access is not just about finance, it's about linguistic and cultural barriers that our doctors, our health professionals are putting to the migrants, and not enough data, as Eva was reminding us.
Yes.
Any strategies, any ways to address that? Because we all know about problems.
Yes, we do. Well, actually, there are only suggestions on the challenges and non-decisions on how to solve them,
okay.
Unfortunately.
I'll go back to you in a minute.
Yes.
Fred, you should have been in that panel. You know an awful lot about this field and vulnerable populations. Solutions more than challenges. Come on.
But it's not in my nature to come with solutions. But,
come on.
but I'll come with a solution. But maybe first a reality check. I'm Freek Spinnen. When I work on the issue of homelessness, we work for a European organization that works on the issue of homelessness. Maybe just to say, to give you an idea of the scope, like we estimate there's 1.3 million people on the street or in a shelter on any given day in the European Union area.
And many
At
of those...
least half of them are migrants, at least. Almost all of them have health problems, physical, mental, and often both together. So the issue of access and health issues with this population, even if you look at only the migrant population, is big. But I would like also to say something. I agree that the Ukrainians on the temporary protection, it has been a success, even if we also see things that are not always entirely right. Overall, it's a success. But asylum seekers, can we speak about that? As well.
Quickly,
yeah, very quickly. One of the first interventions I think you need to do to make sure that people can live a healthy life is to make sure they have a roof over their head. Asylum seekers, they have by law, by EU law, have the right to accommodation. In my country, Belgium, we estimate there is about 4,000 asylum seekers on the street or in squats. That's a violation of the EU law. The European Commission knows that. Yeah. There's other countries in the same situation. The solution, or part of the solution, is to start an infringement procedure against my country. My country has been convicted 9,000 times. My country has been convicted by local judges 9,000 times over the last 4 years, including by the European Court of Human Rights. And nothing happens. Our minister, that's where I finish, our minister publicly says single male asylum seekers are not vulnerable, which from a health perspective is nonsense. They have often mental health problems and other problems. So she says, I'm not providing the accommodation because we don't have enough beds, so they're on the streets. And I think the European Commission should do
I saw lots of tweets from you, Fred, coming out. And indeed, health in all policies is not about the health system only. Can I have more points, challenges but solutions, best practices that you've been talking in your groups? Can I hear some of those? Please, thank you.
So we talked about the language barrier that was addressed also online, but we also talk about the accreditation of curricula. So we have a lot of nurses, not only in the Ukrainian case, at the EU level, as we want to incorporate these new people and make sure that we provide them with labor opportunities, I think it's also important to have a fair compensation, making sure that they train adequately to adapt to our regulation, to our trainings, to the way we are delivering healthcare systems. So looking at the EU level on an accreditation system when it comes to the programs that they have, but also upskilling, reskilling, that could be also a way.
Isabel, I'd like you to listen to that and comment briefly in the final round. All the work you're doing, not now, later.
Thank you.
Later.
From here, you will need to repeat.
Sorry. It's an issue. I had the same problem yesterday when you are there, the sound sometimes.
Okay.
It's an issue, let me repeat it if that's okay. It's an issue of accreditation, Isabel. It's an issue of accreditation of these migrants integrated into the health system. An issue of curriculum, right?
Yes.
Any other ones? Any other areas you discussed in this group? Yeah. Please, one more. Only one.
Well, this to radically include or take the perspective of migrants and people in need and not just defend a status quo, but this will ultimately make you much more resilient if you design a health system, if you design policies that account for the needs of the people primarily.
So you involve this needs assessment, as Ewout was saying, but involving the migrants in that needs assessment, in their perspectives of how they can increase access. I'll come back to you.
Thank you very much.
More things.
Hello, yes. And before I start, I want to introduce myself. I work in health system development in countries of transition, like Kosovo, in post-conflict countries. And I think an important issue is, as it has just been said, the evidence-based approach. What is actually the health status of the citizens? And in 2022, the Lancet, together with our professor, Dr. Zielinski, very famous oncologist, published a statement, what is actually happening to the chronically diseased oncological patients in the Ukraine, how Poland is overwhelmed with the situation, what needs to be done. So this evidence-based approach, number one, needs to be taken into consideration and being communicated also, because it is something we all can relate to. In our countries as well, people suffer from oncology and from cancer, and in this respect, we call them the agencies of counter-populism. We get out of the discussion whether Putin or Zelensky are right, but we get down to very concrete details. Number one. Number two, I think themselves should also be an agent of reality, because we have fantastic professionals coming here and highlighting this fact, looking at this, that medical doctors, nurses, therapists have come here and support now our system, needs to be highlighted and be communicated. And the third very important point is also create bridges back. Because everybody, as it has been said on the panel, actually wants to return, and we do this in Kosovo, for example. We work with diaspora health professionals in Austria who know both systems well and who create synergies, and that again can be communicated. Let's say in pediatric care, there's something we do better in Austria, and something in proctology they do better in the Ukraine. Okay. Start cooperation and have institutional long-term cooperations. Thank you.
It's very much what we had in the policy dialogue with the minister, all sorts of practical schemes, as you're suggesting, to support and strengthen the resilience and communication collaboration. What you came up with? Something new of what you heard?
Yes, something new. Financial and administrative barriers. I think these are two things that need to be talked about, because it's one thing to provide access to services for migrants, and it's another to have them pay for it out of pocket, because this will lead to financial hardship, unmet need, and them not being able to access these services.
So who pays the bill? Someone was saying that here I should pay the bill for migrants. I don't know whether that's true or not. Should you pay
Exactly.
the bill?
So who pays the bill, but also administratively, how do they access? Because in some cases, they need to apply for a card, and to have that card, they need to make applications, needing translation services, but also wait 6 months, 1 year, 3 years for approval to be able to access. So who does the admin for them, and who pays for them? These are two things that need to be talked about. We also spoke about the importance of having governance system to be able to accommodate the overflow of population needs, and to always look at targeting the needs of these populations, which are usually mental health services, child and women services. So these are all things that need to be considered.
Perfect. Caroline, any questions that you got from online? Because I like our panelists to start reflecting on some of those. I'll go back to you at the end.
Yes, there are a few. So mainly questions are regarding the reforms and in terms of financial and structural support. Also, there are questions if there are any way to make the packages more welcoming to migrants, to ensure that they receive the equal healthcare possibilities. And also, are there any strategies for improving the data collection of health status for migrants? Yes.
I'll ask you then, colleagues, you heard these questions, to pick 1 or 2 of those and come up. I'd like you to come up at then with 1 or 2 key measures on my second category of national strategies or international strategies. Be around the finance, be around the administration, be around strategies you know that they're working, that you have experience, you learn, or you read about. Okay? Each one of you. Ewout, I'll start with you. Okay? Can I have more views, strategy suggestions from the buzzing groups here? Everyone wants to be have coffee on time, but anybody wants to add anything? I know very active groups. You're not saying anything? What was your group saying?
Well, our group has dispersed a little bit, so we're still here,
okay.
But we're not sitting together anymore. So, well, I mean, we also find it really important to make a serious distinction between groups of migrants and refugees.
Yes.
And I think it was said yesterday, you know, we have to diversify, which is obviously very important. And we also touched on, well, could we find some opportunity to do some temporary deregulation on professional qualifications? So that people don't feel they're just sitting around being useless, as well as worried about the people at home.
So temporary deregulation, Isabel, do you hear that? Temporary deregulation of qualifications?
I know there is then immediate concerns about, you know, how much will this affect the quality of your services, which is quite a good concern. But there might be some leeway so that people can actually do useful and helpful things based on their actual qualifications and qualities, rather than just sit and wait and worry. There must be something in between the black and white, and we must be able to be a bit more creative with this, both for the people concerned and also for our health systems and our societies.
Perfect, perfect, perfect. I think we are really ready to wrap up, and on time. For once in my life, I'm finishing on time. So, Caroline, anything else you want to add?
Yes. So there is also this. I would like to also to mention that someone said that we really need migrants because. Well, they are not only the problem, like the cause of the problem, right? They are also the solution to make the health system more resilient.
Yes. I like that. Almost could be the tweet to wrap up this session today. The migrants are not the problem, but can be the solution. Dimi, you were agreeing on that? Is that something your group discussed? In a way. Perfect, thank you. So let me come back to you guys, panelists. Can I get one final round? I don't want sort of very big words or whatever. I like to hear strategies that, based on what you heard, based on what you think could be part of a policy to respond to increase the resilience of our health systems. Ewout.
I think the key here is that we need to change and convince everybody that covering migrants, any migrant, undocumented migrant, homeless, all these vulnerable groups is good policy, good economic policy. There's an economic argument, there's a whole body of literature. We need to make it much clearer. Then I think real good policy is that, yeah, you see local initiatives, but we need national initiatives that people are taken care of as well as they are under the Temporary Protection Directive, which is a great example. So in some countries still define who is eligible for insurance on very strict categories. You should just widen that definition of what means, who is a resident in a given country. That includes also these vulnerable groups. Those are things that we need to do. It has to have an integrated approach, because I think the gentleman in the front made a very good point about homeless people needing housing. That is, so it needs an integrated approach that also takes that into account, where possible, allowing people to work. Those are, I think, parts of the solution that come to me immediately, but unfortunately, I do not yet see enough.
Thank you. Jarno, you already gave us quite a lot of very good suggestions by your internally displaced people.
Thank you. But why I was just reflecting why I was able to give it was when I go back to 2023, we started to get first signals that there are access barriers for internally displaced. And especially when there are so many issues, you might actually have a blind spot here and there. So I want to bring up the point of data. And why I was able to give those numbers before was that after we understood it, we are doing, as a WHO, regular health needs assessments within Ukraine. And we started to add special survey parts on IDPs and to understand if there are significant differences. And that's why we have learned that there are significant differences in the beginning of accessing primary care. There are significant differences how they have medicines available. But if you have that data in hand, you can have a dialogue and you can start to put the finger on the topic, and then you can start to solve it. So I think if we have evidence and data, we can start to solve it, and then to help the systems to be resilient.
Which is key to a health system's resilience. And as has been said here, the participation of these vulnerable or less vulnerable populations in this exercise. Isabel, there's been a lot around qualifications directive, ways to integrate them in the health workforce. What would you like to tell us to wrap up?
The professional qualification directive is there, and nobody can escape that, and we cannot cut corner. What we need to do is to support the member state to accelerate the administrative step, and also to help to understand that sometimes it's complicated to demonstrate what you have been doing in a previous life and the paper that you have from a previous life. But I think that there are requirements that cannot be escaped, and even if it seems a silly thing, language is one of them. And what we want is to preserve, delete that was to increase or to maintain the safety and the security of the health system and offer to the whole population the best possible health care, and to the whole population, and using all the health professionals that are available to provide this health care to the whole population.
That's perfect. And it's been a lot to your point about administrative procedures. The legislation is there, the coverage is there, the ability is there, and yet we have to invest more on sometimes accelerating these procedures. Lilian, you told us a lot as well about what you're doing in Greece to strengthen resilience. What is your last message vis-à-vis the migrants?
From a practical policy implementation point of view, I would like to close by clarifying, I think, a big misconception that always comes up when we talk about resilience. The economic sustainability of health systems and quality assurance in health service provision are not mutually exclusive. They're actually mutually inclusive and should be seen hand in hand when it is to promote any policy change in the systems. Because the only way is to do evidence-based approaches, because, you know, we always say in between us and in the ministerial councils in Europe, we don't have doctors, we don't have nurses, we have problems. But in the end of the day, what do governments, what do ministries do for the optimal allocation of the existing resources they have and the very concentrating planning they do for the future in order to be able to adapt. Because maybe it's taken for granted, but it's not, that every government should know exactly what do they have when it comes to resources, to structures, to services, where, what, too much, the need with the supply of our services, but it's not a given. And I think everything should start from there, because if you know your resources, you can plan and adapt to any shock that may come your way in a more prompt way.
Very, very important, very, very key element. Elena, again, I mean, one of the areas actually I was taken is the navigation support. Actually, our colleague Matthias Wismar has published a brief about navigators, not talking migrants, but in general, our population need navigators to support the cruising of the health systems and the integration of health systems. But what would be your last message?
My last message is to reiterate what you just stated. The migrants are part of the solution is one of our key communication messages. So you can repeat it. There is the graphic and all in place if you want to spread the message. And indeed, migrants are part of the health workforce or want to be part of the health works, are leaders in the communities. So the diaspora point, it's very important. They can connect back home and be leaders within our communities, positive leaders. And indeed that they contribute to this navigation and these good practices and ensure that the legal frames that we have, that in many cases are positive, are put into practice and supported by valuable budgets to ensure that the reality happens and the systems are resilient.
Perfect. Thank you very much. Yanis, the last word.
One very operational point, because I think we tend to forget it, and it was made also by the young Gastein here in the front, that there is a whole administrative dimension, right? I mean, how do you integrate these people in the system? How do you set up your mechanisms? How do you reach these populations? How do you even communicate in terms of the language services, etc.? Therefore, from our perspective, as a lot of these issues cover the general population, not only migrants or vulnerable groups, strengthen the coordination and the exchange of best practices, the understanding, how to, especially because these people are going to move inside the European Union. So there is the question of having a consistent approach. Public administration, social security institutions do have questions, and they can learn from each other, and there the EU can play a role, because your question is, what can we do also on the EU level? Therefore, I would say pool resources, expertise, facilitate the exchange of best practices, because that is crucial in order to put in place very practical operational solutions.
I think we're all behind that one. That's beautiful you came back to that. I appreciate that, Yanis, because I didn't touch upon on that. And the role of the EU and the European Commission is fundamental. I will not add anything because a lot has been said. And personally, I learned an awful lot of this session today. Just thanks in my side to Susie Lesov, you and I, Ewout, we free write on all her work. Thanks to the colleagues that's living now of Gastein, Lucia and Orly is living now. Thanks to you, Caroline, to Jan Gasteiner to run the Slido. And thanks to all of you in particular for being here and contributing. I had a lot of fun, I hope you did as well. It's all about fun, learning. And apart from fun, I think it's about coming up with some practical ways forward and not just moan and cry. And I think there have been lots of positive messages about migration and practical ways, and many of them not that expensive, actually, not that expensive. So thank you very much for being here, and please bring your hands together to thank our panelists.